There you go. Bing. We have begun. All right. Quickly, just for just to get. I wanted before I go back into blood sugar at all, and diabetes. Just in the interest of time, I want to get this all done anyway. Certainly don't need to edit those, but I do have it. Okay. We cover this in repro. We'll talk about it. I mean, when we talk about gonads and the placenta, it's really much easier when we get to repro physiology at the end. Estrogens and progesterone, testosterone, pretty straightforward stuff that's here. Uh, Progesterone is the big player for, I beg pardon. Progesterone is the big player for this, okay, which is for the basically for the uterine cycle, the uterine, or basically the menstrual cycle activity, where estrogen plays a more, perhaps I would say, a greater role overall. We'll get to all that. Testosterone basically does both with regard to all of the activities it does. And you can read through that. Like I said, we're not going to have it. And in pregnancy, once the placenta forms, which generally by the end of, let's say, the first trimester, then it really takes over all of these things. Okay, even during formation, as we'll talk about HCG, human chorionic gonadotropin. So all that aside, that's reading material. I'm not going to ask you that. I do not think I have any on the exam. If I do, I will let you know specifically when I look at it. Okay. Again, very, very briefly, because I want to really spend the bulk of the class on diabetes. Leptin is something that does play an important role. Adipose tissue is interesting. I mean, when we start to use up, okay, things as leptin is produced, it plays an interesting role in appetite. It plays a very interesting role in the onset of puberty and it controls vis-a-vis regard varies of the gonadal hormones. I think you'll see that is there. I don't know enough about resistin, this insulin antagonist, to really talk to you about it, or the adiponectin. Okay, so I mean, I have downloaded an AI brief. I think is what we need to know, and I'll take a look at these separately and see what I can come up with regard because these are all from adipose tissue. And so I understand that, at least just to give you the backstory, it's when we utilize carbs and we have insulin. Now we're using carbohydrates as an energy source. It's what happens if we run out of carbs to use, then we start to break down fats. If we run out of fats to use, then we use proteins. You don't want to get to that situation. To some extent, utilizing the fats can be desirable depending on the circumstances. More about that in the discussion. So I'll review to make sure about it. Look at these three specifically and have some additional comments. Let's figure Wednesday for that. And these we get to mostly in GI. Okay, ghrelin is, I mean, if your stomach is empty and you're hungry, this is one of the things that sort of stimulates your appetite. We'll get to that in digestive. We'll talk about this a little more extensively when we get to digestive physiology as well as secretin, cholecystokinin. Okay, and the incretins, again, I'll have to take a look at that when we get to GI. Again, it's this delicate balance between insulin and glucagon that plays an interesting role. We did talk about and that one's important. I'm sure that's on the exam. And we call it remember, it's sort of like the anti-aldosterone. It doesn't work in an identical manner, but as aldosterone pulls back sodium, when there's a fluid overload sensed by the atria and stretches those atrial muscles, small though they may be, effectively it causes sodium to be urinated out. Natriuretic for sodium, uretic for diuresing it or urinating it out. And obviously that's more of the fine control of fluid overload versus fluid underload. We talked about erythropoietin, we talked about already. And again, osteocalcin is interesting. So I think this is something that coincides with insulin and insulin levels. We do see problems with this associated with type 2 diabetes, and this is something that they're looking at. So it's trying to, let's say, optimize the secretion of insulin. And really, type 1 and type 2 is what we're going to talk about today. considerable difference. These in the skin are all parts of are agents that eventually become vitamin D. Okay, there's a precursor substance. Sunlight and vitamin D are integrally associated. You have to have sunlight for vitamin D to be activated. And you can see there's some other roles that are associated as well. I really can't stress enough, as I've done a couple of times, about making sure, and this is hello pot, this is kettle. I'm sitting there with little vitamin D capsules that I should take every day. They're tiny. When you take 3 of them a day, you don't have to worry about it. That's enough of a supplementation. It's not going to cause excessive vitamin D levels, which can be problematic. And it's such I've already got for men, prostate health, for women, breast cancer. There's so many associations with lower, even normal levels that are on the low side. Problematic. And really, there's just too much research coming out. And it's much easier when my wife would give me my bowl full of supplements on a nightly basis with a very simple instruction. Here, take these. Now, again, the usual response was, yes, dear. Hey, that's why I'm here teaching. And this is, again, we get to immune. These are the agents where the thymus plays a role in the development of T cells. And T lymphocytes, they really act locally. So even though they're really less likely to be transported in the bloodstream and more local actors. So they're sort of off the basis there. Okay? So that brings us to really the important topic of the day, which is diabetes and the pancreas. Pancreas, just like parathyroid, is essential. You can't live without it. It's a very busy gland, and one place where you don't want to have the glandular portion, cancers in the pancreas are bad, very bad prognosis because it's so active and so busy. You're already taking tissue that's highly metabolic, and that's an accident that can happen. There's so many people whose lives were taken very, very suddenly. Famous people. It's just not a diagnosis you want anybody to have. Okay. The interior of the pancreas anatomically is where the digestive enzymes come from. They are exocrine in nature. They follow the pancreatic duct. You might remember we talked about the common bile duct, where it joined the bile duct from the liver and the pancreatic duct. It's got a fancy name now called the hepatopancreatic ambula sphincter, but it's a good old common bile duct, and that is exocrine, not part of our discussion. So that comes from these acinar cells, whereas external to that, something that seeps out rather than carried by a duct, hence it's endocrine, are the islet cells. They're called islets of Langerhans, and they're alpha, which produce glucagon, and beta, which produce insulin. And immediately, having these two in effectively next to each other, begins to tell you that they play a role, even though they act directly differently. Oftentimes they act in concert. It's a mechanism. Remember, when you take, and we have the ability to do sugars today. If you're interested in taking random sugar, or go over and invade the Dr. Badger's office, and you can see how a couple of candy bars might pump it up. Always fun. But effectively, it's a random blood sugar unless you haven't had anything to eat. And the interesting thing about sugar is it's kept in a unique way to avoid very sharp ups and very sharp downs. So a lot of times there's almost like co-production of these at intervals. Might be the way to describe it. You don't get a light out of a slide. Here's an alpha cell. Here's a beta cell. Doesn't really matter. I don't think so. Okay. So glucagon, site of action, the liver, triggered by decreased blood glucose levels, also involves obviously other times where we see it when you've had it, like think of rising amino acids, think about a protein intensive meal, and certainly fight or flight, which we talked about. targets the liver, glycogenolysis, gluconeogenesis. So all of this is about elevating blood glucose levels. So here's where we get into sort of this interesting concert, where insulin, as you'll know, coming from the beta cells, acts basically everywhere, synthesized in a precursor or proinsulin form. The different ways it enhances transport, as we're all familiar with. It works outside, G protein passageways that are there, setting off that cascading reaction by way of tyrosine kinase. And so what it does is it effectively enhances the transport of glucose into fat and muscle cells. Good. Inhibits the breakdown of glycogen to glucose. Fine. Okay. And inhibits the conversion of amino acid or fats to glucose. So it's really slowing down, acting opposite glycogenolysis and gluconeogenesis. So those are the major cells acted on glucose into fat and muscle cells, but it's not all of them. Where it's interesting, we do not need this because there are certain areas in your body that are consistently favored and will take glucose as needed. Your brain is surely the single most important one of those. So as you can see, and that's why it doesn't have to rely on some external hormone that may or may not be being produced consistently, or receptors that could be problematic for a variety of reasons. So the brain, the liver, and the kidney. Other aspects, sure, you can make an association with neuronal development, learning, and memory. The tyrosine kinase is a major player, and we all know what it does. It catalyzes oxidation of glucose, and we're all familiar with the metabolic pathway. Not going to go crazy about it. It can take glucose and make glycogen out of it. It can convert glucose to fat, particularly in adipose tissue. So it's got a lot of interesting roles. It's the old story. When we ingest carbohydrates, we utilize as a favored substance what we need to either suffice for our energy needs or the time, or to replenish our energy needs if they've been used up a little bit. Once all of those, for lack of a better term, calories have been taken care of, once you've replaced what you used and what you require for whatever the task is, or whatever the deficit was, at that point, what do we do with the leftover ATP? Okay, gets converted to fat. That's the interesting thing. It's really what part of today's discussion is to sort of understand what it does when there's excessive glucose, why it is what we call a pro-inflammatory agent. I'm hopeful, and I would be very thankful to know that all of you are doing okay physically, and do not have some long-term chronic inflammatory condition, some kind of arthritis, okay, things like that, some autoimmune disorder, though they're more common than you think. But there's a lot to be said about glucose or carbohydrate restrictive diets if they're done appropriately. I know I feel better when I do it. It's just I have a major problem staying up with it. It's these guys. It's my proverbial sweet tooth and this remarkable affection I have for bread. Sorry, I'm a carbaholic. I'm in Carbaholics Anonymous. Simple, complex, irregular, atypical, typical. So the atypical would be wheat bread and rye bread, garlic bread. It'd be nice if you would contribute with occasional smile here. Don't love any of you. So influence, elevated blood glucose levels, the number one stimulus that's there. So when you ingest that carbohydrate immediately, very, very quickly, that's going to cause a distinct change in blood glucose levels. So the levels of amino acids, and again, things like that, other things that you ingest as well will cause a raise in this. So it's not only carbs, but also amino acids and fatty acids. Acetylcholine, by the sympathetic nerve fibers, plays a role. All of these things, okay, have played some degree of a role with regard to these things. Glucagon typically opposes it. Epinephrine increases the same thing, acts on the liver, causes glycogenolysis and gluconeogenesis. Growth hormone acts opposite of it. Thyroxine probably works independently of it. And the glucocorticoids certainly continue that process acting in the liver. So there's a lot of different things that are involved. They're all influential. So actions in the sympathetic nervous system, and even somatostatin, which is sort of like the anti-growth hormone. So somatotropin is growth hormone. Somatostatin blocks it. There's always involvement with regard to insulin. So it's very complex. And I don't love to do those. So effectively, we are dealing with a condition called diabetes mellitus or mellitus, doesn't matter. But you should be specific. Believe me, on a test of mine, if I say diabetes, it's diabetes mellitus. If I wanted you to know about diabetes insipidus, I would put that. If you have a question about, if you see both of them on there, then that would be a way. That would be one of the answers to one of the questions that I'd be giving you, scenario or description. But if I just say in diabetes blank, there's no type 1, type 2 in diabetes insipidus. So mellitus can be due to one of two things. Very straightforward. Not enough insulin, an absence of insulin, a limitation amount of insulin, or the insulin doesn't work effectively. There's adequate amount. Something is going on with the receptors, the targeting receptors. So they told me you were delayed. Did you ever see our two wayward classmates here? It's terrible. Okay, that's all. So, what effectively happens? So we'll look at the distinction between type 1 and type 2 and what effectively happens with regard to this condition. So the best way to describe it is, for whatever reason, whether there's insufficient amount of insulin or the insulin doesn't work properly, you have glucose in the bloodstream. Again, diabetes means the great thirst. The difference between mellitus and insipidus is that the urine then has an abundance, an excessive amount that it can't reabsorb of sugar. So what happens with this extra sugar? Your body has, and we may have talked about it a little bit in anatomy, in the kidneys, they have something called a transport maximum. Typically, our kidneys can reabsorb up to about 185 milligrams per milliliter or deciliter. In other words, if you test your sugar today in lab, that's the measurement, milligrams per deciliter, what we call milligrams percent. Your kidneys can pull back as long as if your number is up to 185, it will pull that back in approximately, assuming you're healthy otherwise, and hold on to that sugar. Anything else over that will spill over. The problem with a transport maximum, when we review this, when we get to the kidney, is the longer you're at maximum, over time, it damages that mechanism. So if you're at 185, if your blood sugar is 200, and you're having to use this maximally, that maximum ability it's going to damage that mechanism, and over time it'll go down to 170, 165, and that's why, ladies and gentlemen, it's so terribly important for very, very aggressive management of diabetes, because that's really when we start to see secondary problems. So, I mean, the watchword for the very longest time, since I've been studying this, and I've been studying this disease 50 years ago, it's aggressive intervention early. We do it as a family. We get involved with parents, children, spouses, everybody, significant others, whatever your definition is. Everybody, they talk about it takes a village. It's hard for one person because diabetes is a tough disease to deal with. And it's not a disease per se. This is really a syndrome. A syndrome is a compilation of symptoms, signs and symptoms that manifest themselves in a certain way. So it's a syndrome that is highlighted by the inappropriate usage of sugar, typically characterized by excessive sugar in the bloodstream, hyperglycemia. So now back to what happens in the kidney. And this is what we call the three polys: polyuria, polydipsia, and polyphagia. So there's so much sugar that's spilling over into the urine. It's like any other solute, it pulls water to it. Remember, Mary had a little lamb rule for sodium? It's going in the other direction. The sugar is pulling water, so you urinate more. Okay? Glucose acts as an osmotic diuretic. Polydipsia. Well, if you're putting out too much water, you're thirsty. Polydipsia. And because the cells can't utilize the glucose that they need for energy, that tells your brain, well, I'm not getting enough energy and I'm hungry. Vicious cycle. Sugar's floating around in the bloodstream excessively. Your cells say, eat more. And you're like, okay, I'm hungry. Boom, you crave. Those are the three polys: polyuria, polydipsia, polyphagia. The fluid lost by the osmotic diuresis is why the great thirst or excessive thirst. The other thing is characterized when it's out of control: fatigue. Because the energy, you're not getting producing enough ATP in the cells. So to me, it was always the three polys plus fatigue. There's a lot of things that play a role in this, but those are really important to remember. When we can't use them, what do? We start to use fats. That's the pecking order. If I can't get it from sugars, we go to fats. If I can't get it, if there's not enough in the fats, I got to go to proteins. And you start breaking down proteins, you're in big trouble. Because that's what we see with people with starvation due to malnourishment. Okay, malnutrition is defined by utilizing your proteins as a fuel. So, as in diabetes mellitus, fats are used, causing a lipidemia. What happens, and you study this in cell and molecular. How do we break apart fats? We don't take a knife. We don't take a scissors. What's the mechanism that fats are shuttled into the Krebs cycle? Pardon? I just didn't hear. I'm sorry.
No, I'm thinking of the wrong thing.
Okay. Beta oxidation is correct. You have those two, remember, it's two carbon units, an alpha and a beta. See, I took that course. I was a chemistry major, believe it or not. So we beta oxidize them. That leaves those. And what happens when you have excessive amount of effectively even short chain, much less long chain fatty acids in the bloodstream? They have an annoying tendency to slam into each other. And they make something called keto acids and ketone bodies. They are bad. So ketones are acidic in nature, and we get ketoacidosis, we get and ketonuria. And understand that when we talk about the keto diet, which is the same, which is very similar to the South Beach diet and the Atkins, it's been around forever. These are collectively called carbohydrate-sparing diets. The last time I was on it, I got my weight down to, I was under 187. I was 187 for my daughter's wedding. Now I'm probably 20 pounds, which is why I have to wear these. There's an obstacle in the front. So very soon it'll be goodbye to my beloved carbohydrates for a while and on to keto. What happens is you play, and with all of these diets, you play a metabolic trick on yourself. It has been around, that diet has been around for 50 years. They're all the same, basically. The metabolic trick you play is, okay, I'm not going to eat carbs, or I'm going to restrict them to a minimum number a day. And you can calorie count, you can count the amount of carbs, and then that's what typical keto, people who are into this, it's a whole subculture. It's a very popular diet. and then you basically, it's a diet that is probably 80. People go, my God, 80% fats. You're going to eat like a side of bacon every day. Not that there's anything wrong with that. Sorry, I know, Jewish. It's hard. You can't eat pork, Jewish, that type of thing. It's okay. I don't believe you are what you eat. Lord, forgive me. But because of that, the whole idea is you consume what are healthy fats, foods that are rich in omega-3s, not rich in omega-6s. You find you use avocado oil and extra virgin olive oil. You stay away from the canola and the vegetable oil and the corn oil. All of those burn badly. You end up with, you eat salmon for omega-3s rather than something else is made with that. All of that. So you get the idea, because those are fats that are worse yet than your system, because they're, by their very nature, much more inflammatory and much more likely to cause problems biologically. And so what happens, you put yourself, effectively, you're scientifically putting yourself into ketosis. And what happens in ketosis, you're breaking up your own fats, okay, in the process of making a major metabolic component for energy, fats. Interestingly, you are much more energetic because you all took metabolism. You get more bang for your buck with fats than you do with carbs. Okay, that whole beta oxidation thing is a more efficient process. It gets put right in. You good old coenzyme A. That, remember that? The old transition step. See, I took this. And what happens is that it immediately increases your energy levels are dramatic. Mine aren't that bad for somebody who's my age. Okay. As much as I'd like to be sitting on the porch with my, in the rocking chair, not happening. So what happens is those ketone bodies are basically, you're breaking up fat, and as long as your kidneys work sufficiently, as long as you're hydrated sufficiently, as long as you're eating the appropriate fats that are part of the breakdown process to supplement your own fats that are breaking down, you lose weight and you lose inches first, which is the very sort of rewarding thing for dieters. Look, I used to weigh 280. I know I've gained and lost people. So much fun when you go to your 40th and 50th high school reunions and they don't know who you are. Yeah, I refuse to wear one of those "Hi, my name is" things. You guess, sucker. So untreated, you're acidotic. You have to breathe excessively to blow off carbon dioxide, right? All of those things, the acidotic levels disrupt all of the following: heart, oxygen, nervous system, very severe. Again, high blood sugar and this kills you slowly. It takes a while to get to that stage. Once you're at that stage, it's extraordinarily difficult to deal with. Low blood sugar kills you rapidly because once your sugar falls below 50, your brain is getting an insufficient amount of sugar. You go down right away. Like somebody's sugar bottoms out, they're going to feel faint, dizzy. I don't know if it's ever happened to you, okay? But it does happen to a fair amount of people, myself included. Myself probably has more to do with eating too many carbs and because of the stomach surgeries I had. That typically is part of the process. So I'm sort of a double whammy. It's associated with it. So people have excessive insulin secretion, leads to low sugar, and this is what I mean: anxiety, nervousness, disorientation, unconscious, even death. And the treatment is sugar, as you might guess. I had so many. I remember I treated diabetic patients for a quarter of a century. More than one of them had the experience, and I probably shared this with you already, but it doesn't hurt repeating. They're in a hurry to get to work. They take their insulin. They forget to eat something. Oh, I'll eat when I get to work. I mean, surely my all-time favorite patient who's no longer around for us. There wasn't a whole lot 3 years older than I. Such a brittle diabetic. He did that. He's fortunate that because he woke up in the emergency room. It's like in the movies, they give you a shot of sugar, and it's like, where am I? Perfectly back to normal. They found him because he opened his car door when he parked at work and fell out of the car. He's right by Titusville, if you have any idea where that is. Okay? Up in Titusville, PA. Because he worked right alongside the campus at a senior citizens facility. He's lucky that didn't happen when he was on the way to work and drive into somebody, because he would have lost control of his car or into a tree. Well, I can't emphasize how important it is if there's somebody, and all of you are going to have people who are diabetics in your orbit, to make sure that they're aware of that. If they're on insulin, if they have frequent bouts of hypoglycemia, that you can't allow yourself to get into that situation. It's just too dangerous, not just to you, but to everybody else. And I mean, he was not the only one, but he was the most memorable one. So that's one of the things I think I told you, when a diabetic comes into the emergency room and they have in their wallet, maybe they have a bracelet, maybe they have a family member, Uncle Bob's a diabetic. The first thing we give them is sugar. We don't care if it's 700, you give them sugar so it's 800. Same problem. It's 50, you save their life. D50, dextrose 50%, IV push. Get to the problem right away. And it just goes over all these things. And let's see what this has to say for itself. Oh no, I'll see if it plays. Give me sound. Oh, I gotta have sound here.
Power enters your digestive system and is broken down to simple sugars like glucose. Glucose enters the bloodstream, causing an increase in blood glucose levels. But various mechanisms bring blood glucose back down to its normal level, the set point. This is an example of homeostasis, the body's tendency to maintain relatively constant internal conditions. Hormones produced by the pancreas regulate blood glucose levels. Let's zoom in. When blood glucose levels are high, glucose molecules leave the blood and enter beta cells in the pancreas. The beta cells respond by releasing the hormone insulin. Insulin enters the bloodstream and is transported to cells all over the body. Let's see what happens in the liver. Insulin binds to receptors on liver cells. This causes the cells to take in more glucose. Inside the liver cells, glucose is converted to glycogen, a storage molecule. Blood glucose levels decrease as glucose is taken up by liver cells and other body cells. As a result, less and less insulin is released by the pancreas, and blood glucose levels stabilize at their set point. This is an example of how negative feedback maintains homeostasis. What happens if you skip lunch and your blood glucose levels are low? Let's zoom into the pancreas again. When blood glucose levels are low, alpha cells in the pancreas release the hormone glucagon. Glucagon enters the bloodstream and acts on target cells in the liver. Glucagon binds to receptors on the liver cells, signaling the liver cells to break glycogen down to glucose. Glucose is released. And blood glucose levels increase. As a result, less glucagon is released by the pancreas, and blood glucose levels stabilize at their set point. In this way, two hormones with opposing effects allow the body to maintain homeostasis of blood glucose levels. In diabetes, the body is unable to maintain homeostasis of blood glucose levels. In type 1 diabetes, the beta cells of the pancreas are destroyed by the immune system, and so no insulin is produced. In type 2 diabetes, the pancreas produces insulin, but target cells do not take up glucose. In both types of diabetes, when blood glucose levels rise, cells do not take up the additional glucose, and so blood glucose remains high. This example shows the importance of homeostasis in everyone's life.
Good for that. So, okay, let me get to the rest of my presentation. So what I put up there, you already looked at that slide. What I put up there, the word is maybe uniting type. So there are two types. Years ago, now we call them type 1 type. Years ago, we called them use onset, maturity onset. So typically, if 40 was typically the cutoff. If somebody had diabetes before 40, we was called juvenile or youth onset. Of over 40 was maturity onset. We realize now that we don't understand it as well. The vast majority are of type 2, meaning over time, they may have indicators early on, but over time, the receptors have either changed, altered, or become defective due to genetic mechanisms and other mechanisms to allow the insulin to be utilized properly. A very relatively small amount is due to true poor production or complete lack of insulin production. So, and the funny thing is, now we see type 2 is becoming increasingly more prevalent in younger individuals, and we still see type 1 throughout. Some people just develop it later in life, when for whatever reason their insulin production wanes. The difficulty with type 2, we call it metabolic syndrome or syndrome X. When we see it in young people, it's horrifying. It has to do with societal problems. You're all sitting there looking at laptops and computers and pads and things like that. It's so totally different. I'm a poor example to talk to you because I'm basically lazy and not terribly active. Like I said, I didn't see the inside of a gym until I was 55 years old. I'm afraid of perspiration. The reality is that a lot of young people today are, whether it's gaming, whether they're just enthralled to stick in front of their computers and watch YouTube forever or whatever you're watching, doesn't matter. There's no, it's the lack of physical activity that's causing significant problems. Okay, that lack of utilization is eventually going to lead to significant problems. And when you start seeing ketoacidosis in teenagers, there's a big problem. I mean, it's totally different today. I mean, there's a lot of factors. Parents are reluctant to have their kids go out depending where they live. There's appear to be a whole lot more predators out there, a lot more dangerous. I understand that. In our day and age, it was different. I didn't like to be active, but our moms next to us out of the house after school. I don't want to see you until 6. Having dinner. And they yell at you for coming back filthy. They want me to play. It was different. They didn't worry about it. You knew if you got in trouble at the playground, your mom knew about it before you got home. It's a network of moms. Sure.
I was going to ask, back then, was there like a predator that kids?
Pardon?
Because like nowadays we have like predators that are out there. Is there a threat back then?
I don't think so. That's how I recall. There were occasionally kids snatched up shit. We didn't have the media to know this. Honestly. Typically there was, like I said, the moms, everybody was kind of watching after her. They saw somebody unfamiliar at a big playground at the corner from my house. Somebody's there calling. Cops do a drive by and it would be like, they weren't shy about saying, what are you doing here? I don't see you. It was a different kind of a thing. least we're not shy about using enforcement techniques to dissuade you. That's why I like to say KATN, your gas station. You did. So, I mean, all of those things. And now, I understand it from a parent perspective. As soon as I look back on my kids, oh, with you folks, I just think there's more. I don't know what to call it. I don't want to speak badly about people because you can be in their shoes. Nevertheless, the test for years was called the glucose tolerance test. Living systems don't make sharp turns. Normally, there was suspicion they would fasting overnight. And roughly here, they take a blood level, let's say it was normal, around 70 to 100, 110, whatever, 65 to 110. And they give you in that first half an hour a test load of sugar. It's generally like a sweet cola, with a cola or an orange drink that you had it down every 15 minutes. And then that would immediately jump your sugar up. And over the next, and the critical part was here, the 2-hour one. And then you would be able to, if that came back to normal, you would plot it out into your blood for half an hour and plot out the curve. And what you didn't want to see was something where somebody was making, where you start to see things like this and things like this and that. Sharp turns are bad. That means, because what happens is it's the dynamic antagonism, the give and take of insulin and glucagon. Glucagon would kick in. If it got too low, as it started to be, if it was a sharp curve, it would diminish it, would round it off. So we didn't, so you would look for the curve itself to see if it was drastic in that nature than rather than presume. And sometimes it's either for 3 hours or 7 hours. That was the acid test. I mean, if somebody had somebody's fasting blood sugar, after a test on a fasting blood sugar was like 150, hey, they're diabetic. It's the ones that were crazy. Now it's a little different. We can do regular blood sugars, fasting sugars, and we can do tests like that if we need to. But we have the magic of hemoglobin A1C. Hemoglobin A1C, or glycosylated hemoglobin, is a wonderful test that detects the degree of glycosylation of your hemoglobin molecules. And not only is it a diagnostic test for diabetes, it also is a diagnostic test for how well your treatment is going. So now we see more. It used to have to do, we call it 2-hour postprandials. You fast, tell somebody eat breakfast and test their sugar 2 hours later. Give them an idea what to eat for breakfast. So that was a good, but now you can look at the fasting levels to sort of keep a handle on it and then address accordingly. And there's a whole lot of different ways to be able to treat it. So in summary, in the few minutes I have left, I'll show you what I put together, and I just included it on the blackboard. And this is me doing a quick AI thing just to give you an idea. Why is it so darn bad? We learned back in the day it caused basement membranes to thicken in blood vessels. It's really not how it works. That's one of the effects. But what happened with causing irregularity in the lining of blood vessels began to produce, remember when blood flows, and we're going to talk about that in the blood unit, blood has to flow smoothly. It doesn't do well. It's like it's the old lazy river versus raging rapids. Okay, in Pittsburgh East. You probably didn't have that up at St. Mary's. So it's supposed to be like that, smooth, laminar flow. What happens when you have irregularities along the way, like going down and doing the Akagami, you're just watching those areas, slams together, platelets slam together, blood clots. Here, so that's really part of what we begin to look at, why there's so many problems with clots forming in various vessels. This is just some of the backstory. So it causes vascular damage primarily through chronic hyperglycemia, which triggers oxidative stress, and that means toxic derivatives of oxygen, and inflammation. Formation of a gland, and you don't have to know any of these terms, this is more for me to share it with you. Advanced glycation end products. So they impair the lining. Remember we talked about nitric oxide, this wonderful vasodilator that's so critical today, that really, as long as we have that, if the vessel gets pushed on, it releases nitric oxide, so it dilates. Here, it doesn't do so as effectively. So when you take that away, it promotes stiffness or hardening of the arteries, accelerates damage, atherosclerosis, fatty deposits, and later over time those calcify. It creates an inflammatory change. It's kind of why for blood clots, where people have, if they've had like heart surgery, they'll take a baby aspirin a day because it stops platelets from aggregating. So it's a useful anti-clotting agent if you in small cases. And microvascular disease, the big problem is retinopathy and nephropathy, leading cause of blindness, leading cause of kidney failure, diabetes. We're seeing a pattern here. And those are microvascular, these are macrovascular. Coronary artery disease, stroke, which is cerebrovascular disease. So these are the pathways. The lining leads to excessive ROS, reactive oxygen species, reduces nitric oxide, tending for vasoconstriction and permeability. These end products, high glucose binds excessive amounts. This is the Dr. Hillwig of it. Binds to proteins and lipids that cross-link with collagen. Okay, so that's where the basement membrane began to be damaged. That basement membrane damage, eventually, as you can see, vascular stiffness and impairing cellular adhesion when it's supposed to occur there. Oxidative stress leads to inflammation. Sugars are very inflammatory in nature. And you see they interact with you. Again, NADPH, oxidase activation, induces inflammation. So, I mean, these are the combination of reactive oxygen species with this. Because the more sugars, the more, it's almost like you're forcing your system to be overly metabolic in this regard. Past hyperglycemia creates lasting damage, epigenetic changes, inflammation, vascular damage, even if blood levels are controlled. That's why you control them aggressively. And here, the end products. Endothelial dysfunctions, metabolic disorders, plaques, fatty byproducts, prothrombic states, blood clotting, etc. So this is all part of that process. There's so much complexity. We would go to seminars because the lower extremities are affected more than anything else. When you talk about losing limbs, dry with various kinds of gangrene, which is a whole different discussion. I do more of that in micro and infections, which is not a vascular disease. And it's so tragic. I don't know that it's necessarily always avoidable, but it's tragic because there's precautions that one can take and signs to look for. I mean, I spent an entire career dealing with those problems, and it's very, very difficult. I said diabetics are, because they crave sugar. I mean, I tell everybody the same story. I would do house calls. Okay, young, you'll go anywhere to try to get a few dollars. This lady had already lost a leg. She needed somebody to cut her toenails at bedstead. She rarely got out of bed. Didn't like to wear a prosthesis. And I go in there, and that leg was clearly not doing so great. And she wasn't that old. I mean, she couldn't have been more than 60 years old, as I recall. And what's in her nightstand? Candy bars. I mean, I can appreciate that. I love candy bars. But then again, I'm not a diabetic. But that's what I mean. Their craving overwhelms them. Look, I mean, she wasn't going to live that much longer, unfortunately. The disease was getting worse and worse. And I had to, and doctor, you have to tell them, don't do this, don't eat this. But the reality is this just a bad thing? But you get to a stage where magically you're not going to correct it. There's a fine line. So that comes over time and things like that. So I'll leave you with that, with our discussion of diabetes. I will be happy. I should have told you about pre-diabetic conditions. I'll make a mental note and I'll get a little mini presentation for 5 minutes on Wednesday with that. When do you want to have this exam? I never is not acceptable. Pick a day on the last week. When do you have an exam on the last week that's already spoken for? Before